Hello, Lindsay, and hello, Fabiola. Welcome to this class. We're going to go ahead and get started since this is going to be recorded anyway. So the people who are coming in late can always review the recording at some point in time. Our topic for today is actually a combination of septic shock complicated by ARDS. So let's begin this discussion by talking a little bit about sepsis, because that's the precipitating event that caused the ARDS. So sepsis is a life-threatening medical emergency, and this is caused by an exaggerated or overblown response to infection. And it usually is caused by a bacterial infection, but it could also be due to viral infections, like, for example, COVID-19. Now, the pathogens that are usually associated with sepsis are E. coli and Staph aureus, and these are some of the most common organisms that are going to cause these particular infections. And these infections lead to sepsis, which could begin in anywhere in the body. And like, for example, the most common site of origin is going to be the urinary tract, but it could also be from the lungs, the skin, as well as the GI tract. And so sepsis and septic shock are medical emergencies, and therefore it is important that we are knowledgeable about the nursing interventions as far as this state is concerned. Now, diagnosing sepsis is both challenging and complex. And oftentimes patients arriving, for example, in the emergency room are febrile and have shortness of breath, low blood pressure, a high pulse, and respiration. These are symptoms which can easily be confused with other conditions. So there are sepsis bundles, and you hopefully are familiar with bundles. Bundles are a series of nursing interventions or tools that healthcare organizations use to implement evidence-based guidelines. And this has been recognized to improve outcomes in the treatment of specific diseases or conditions. So in this particular situation that we're talking about the sepsis bundle. So there has been some revisions to the sepsis bundle because it requires the incorporation of evidence. And that's the reason why, since its inception in 2002, the bundles has had some revisions and actually has led to more appropriate care in the treatment of sepsis and has improved outcomes and survival. So what are some of these bundles? Let's just examine this particular slide to look at the events or the implementations that nurses must be familiar with. To be completed within the first 3 hours are the following. We need to measure lactate level, and of course, obtain blood cultures prior to the administration of antibiotics, as well as administer broad-spectrum antibiotics. And we're going to start resuscitation with fluids by giving 30 mL per kilogram of crystalloids for hypotension, or any time the lactate is over 4 millimeters or equal to 4 millimeters per liter. Okay, so I'm going back to these bundles later on, but let's take a look at the first hour bundle. The first hour interventions are going to be very, very important. And the first one is to measure the lactate level. And any time that the lactate level is low and we suspect that the patient might be septic, we need to repeat the tests. Now, the value of measuring lactate in the diagnosis of sepsis is because of the fact that when we measure lactate levels, it provides us with useful information about the progression and the seriousness of the condition, as well as we could use it to monitor the effectiveness of treatment. So you might be wondering, what is lactate anyway? Well, lactate is a chemical naturally produced by the body to fuel the cells during times of stress. And whenever it's present in excessive quantities, it is commonly associated with sepsis and severe inflammatory response. So lactate is going to be a very valuable metabolite that we're going to, one, diagnose the presence of sepsis, and number two, to determine the progression of the disease and evaluate the effectiveness of treatment. Now, naturally occurring lactate is normally cleared by the liver and the kidneys, and the blood lactate concentration in individuals is going to be less than 1 to 1.5 millimeters, milliosmoles, per liter. So we usually are able to clear that. But in critically ill patients, however, these patients suffering from shock or hypoperfusion, lactate is often elevated to about 2 millimeters per osmoles per liter. And so whenever we have a lactate above 4, it indicates the need for immediate resuscitation, and you must call for rapid response team. All right. So again, look at number 4. I would like to emphasize that this is something that would come up in the Nclex. Whenever the patient's lactate level is greater than 4 milliosmoles per liter, this is considered to be an emergency, and you need to activate the rapid response team in order that specialists will be able to monitor as well as to manage the patient's condition. So the second thing that we are going to do is to obtain blood cultures before administering antibiotics. And then, of course, the third step is to administer broad-spectrum antibiotics. Now, you might be wondering, are we going to wait for the culture result to come back? And the answer to that is no, because blood cultures will take approximately 3 days to come back or to return. And therefore, whenever we suspect sepsis, we immediately administer broad-spectrum antibiotics after blood cultures have been obtained. And this is going to be the reason why we use broad-spectrum antibiotics. Then we can always change that whenever the blood culture and sensitivity will come back. And now, the fourth step is to begin rapidly administering 30 mL per kilogram of crystalloid for hypotension or lactate levels of 4 milliosmoles per liter or greater. And the reason for this is, what happens when you have septic shock? Are you vasoconstricted or are you vasodilated? Can you type your answers? When you are in septic shock, are you vasoconstricted or vasodilated? All right. So this is what I'd like you to remember in patients with septic shock. Because of the toxins that are going to be released by the microorganism, by the offending microorganism, there's going to be massive vasodilation. And so when you are massively vasodilated, what happens to your blood pressure? You're going to have a decrease in blood pressure. So it's always important that whenever you are looking at a patient with shock, you're going to think vasodilated. And therefore, the treatment is going to be fluids, fluids, fluids in order to expand the extracellular compartment. And lastly, we're going to give vasopressors if hypotensive or after the fluid resuscitation in order to maintain a mean arterial pressure of greater than 65 millimeters of mercury. So that's the magic number that I would like for you to remember. We would like the MAP, or the mean arterial pressure, to be 65 millimeters of mercury or more, okay? So the MAP, or the mean arterial pressure, needs to be at 65 millimeters of mercury or greater. And so sometimes you're wondering, what is this mean arterial pressure? So mean arterial pressure is going to be a product, oh shucks, sorry about that. Mean arterial pressure is a product of the diastolic blood pressure plus 1/3 of the systolic pressure and this would be your mean arterial pressure. So let's see if you could solve this one. Let's say that your blood pressure is 90/50, okay? So your diastolic pressure is 50, and your systolic pressure is going to be 90. 1/3 of that would be 30. So your mean arterial pressure is 80. This is a good blood pressure. See, we are so used to looking at the systolic and diastolic pressures when in fact the mean arterial pressures are much better to assess circulation. So let me repeat that again. So mean arterial pressure is the product of the diastolic blood pressure plus 1/3 of the systolic pressure. Okay, so I want you to solve this. Supposing a patient's blood pressure is 80/40, what would be your mean arterial pressure? Anybody? Yes. Okay. Good, Lindsay. Very good. It's 66. So in this particular instance, is this good? See, if we're just looking at 80/40, we always think, oh my God, this patient is dying, right? But if you look at the mean arterial pressure, circulation is going to be maintained at a mean arterial pressure of 65 millimeters of mercury. And ain't no wonder sometimes you're thinking, why are they not treating this blood pressure of this patient? And that's because the 80/40 looks like it's very low, but in actuality, there's still good circulation being maintained. But let's say your blood pressure is 70/40. So let's see how this is going to occur. So this is going to be 40 plus 70 divided by 3 is going to be 23. This is about bad blood pressure. Okay, so do you get that? So in your practice later on, never only look at the systolic and diastolic blood pressure. it is much more important to look at the mean arterial pressure. Okay? All right. So those are the first hour interventions as far as resuscitation of patients suspected with septic shock. All right, so let's take a look at this first poll. Okay, wonderful. So you remembered it is vasodilation, not vasoconstriction. Vasodilation and not vasoconstriction occurs because of the body's immune response. You remember they release toxins, and they are the ones that causes this vasodilation in blood vessels. Okay, so let's go to the next poll.
Is this multiple choice? Is this
Select all that apply. Yeah.
It only allows us to pick one.
Oh, I'm sorry. I probably did not activate the multiple choice. Okay, I apologize. All right. So let's go to it one by one then. All right. So let's take a look at letter A. Your patient is treated for septic shock, which findings demonstrate that treatment is not being successful. So letter A is going to be good or bad?
Bad.
It's bad, right? Okay, so this means to say that it's not being successful. The treatment for the septic shock is not being successful. How about a urine output of 10 over 2 hours? What is the normal urinary output for an adult? Well, we usually should have around 30 cc's per hour. And so over here, 10 mLs over 2 hours is going to be very bad. So that means to say that this is also a correct response. A serum lactate of 15. What did we say was the normal lactate? All right, so less than 2, right? And if it's 4, we're going to activate the rapid response team. So this is really elevated. So this also is not going to be a good one. And then, of course, the other one is a blood glucose of 120 milligrams per deciliter. We're not treating diabetes here, so this is not a parameter that would be appropriate for this condition. And then, of course, the last one, a CVP of less than 2 millimeters of mercury. What is CVP? Central venous pressure. Just think about the amount of blood that goes back into the right atrium. If you're measuring the pressure that's generated by the volume of blood that returns to the right atrium, this is CVP. Okay? So if your CVP is low, that means to say that you have hypovolemia. If your CVP is high, then that means to say that your your volume is going to be high. You have hypervolemia. All right. So a central venous pressure should be greater than 2 millimeters of mercury, but not more than 8. So therefore, this particular finding is also going to be an abnormal one. So let me just write that down because I want you to remember. All right. So what does CVP reflect? CVP, or central venous pressure, if this is the right atrium, the amount of blood that goes into the right atrium is called preload. If we measure the pressure generated by this preload, this is what's called CVP. So what would cause an increase in CVP? Well, hypervolemia, for example. Or let's say that your ventricles are not working well, like in heart failure, you would also have an increase in CVP, so heart failure. Low CVP would therefore mean that you have hypovolemia. All right? So again, the CVP should be between 2 to 8 centimeters of water and millimeters of mercury, I'm sorry. And therefore, this particular question shows that the CVP is less than 2 millimeters. So that's bad. Okay. All right. Let's go to another poll. Again, I forgot to put the multiple choice, so we're gonna have to go one by one. All right, so in addition to A, can you type which one or another one that would indicate that the patient is progressing to septic shock? In addition to letter A, what else do you think? Very good, Fabiola and Chantel. All right, good. Now, the other response would be letter C, okay? So letter A, blood pressure of 70/34 after the fluid bolus. And letter C, patient needs norepinephrine to maintain a mean arterial pressure greater than 65 millimeters despite fluid replacement. So to know if the patient is progressing to septic shock, you need to think about the hallmark findings associated with shock. Septic shock is characterized by persistent hypotension that doesn't respond to IV fluids or vasopressors. And when I say vasopressors, we're talking about drugs that increases the blood pressure. So what are some of the other drugs that you can think of that would increase blood pressure that we usually use in patients who are needing resuscitation as far as blood pressure is concerned? Well, you've heard of dopamine, for example. Anything that ends with INE is going to be an example of that. And my pen does not seem to be cooperating with me. All right. So the other vasopressors are dopamine, and dopamine is also known as inotropin, and then epinephrine, and then, wow. And the other one is norepinephrine. Sorry about that. It's moving faster than me. Okay, there you go. Epinephrine and norepinephrine. The other name for norepinephrine is Levothed. That's the trade name. All right, so those are the most common drugs to raise the blood pressure. Okay, so what else? A serum lactate that is less than 2 millimeters is going to be normal. A serum lactate is not normal, but it's not that elevated. A serum lactate greater than 2 indicates that the cells are not functioning properly because they're low in oxygen. And therefore, it means that tissue perfusion is poor because of the low blood pressure. All right. So we said that the normal mean arterial pressure was 65, but we never said what the limit was or the maximum. So it's anywhere between 65 to 100 millimeters of mercury. Okay. So that's the reason why also a high blood pressure is not good as well, because we need to maintain a normal mean arterial pressure between 65 to 100. All right. Are there any questions as far as this one is concerned? Okay, so I also would like to write the normal CVP. Now, CVP could be measured in millimeters of mercury, and so we said 2 to 8 millimeters of mercury. And the other measurement is actually centimeters of water, and that's 4 to 12 centimeters of water. So please make sure that when a CVP value is going to be given, you need to determine, is it millimeters of mercury or is it centimeters of water? All right. So the normal CVP again is going to be 8 to 12 millimeters of mercury, and it is going to be 4 to 12 centimeters of water. Okay. So let's go now to a discussion on ARDS. We have talked about septic shock, and now we're going to ARDS because this is the case study that we have today. So what is ARDS? It stands for acute respiratory distress syndrome. This is a life-threatening injury, lung injury. And what happens in this lung injury is that there's going to be fluid leaking into the lungs. And we're going to talk about why there's going to be leaking of fluid into the lungs. ARDS is a very serious condition. It results in breathing difficulty and oxygen not going into the tissues. And that is the reason why these individuals are going to be very sick. In fact, ARDS has a very high mortality rate. Approximately 35 to 45% are going to be, will result in death. So this means to say that it's going to be very serious. So if we said that in septic shock, there's going to be vasodilation. Imagine that this is a blood vessel that is normal, and contrast that to a blood vessel that is going to be dilated. Now, if you dilate a rubber band, will the walls of that rubber band become thicker or will it become thinner? Okay, so it will become thinner, isn't it? All right, so the purpose why we have a thick capillary network or blood vessels is because we want to keep some materials or matters like albumin within the vascular bed or in the blood vessel. Maintaining the amount of albumin inside the blood vessel is what is known as an oncotic pressure. So it allows, therefore, to attract fluid to go naturally to the blood vessels. And that's why you have circulation of fluid. Now, what would happen when you dilate the blood vessels? Lindsay said that it would become thinner. So what happens then is these matters, the albumin, are now going to go out. And so when albumin and these big particles are going to go out, what's going to follow? Fluid. And that is exactly what's going to happen when you have severe vasodilation. So let's take a look at the severe vasodilation occurring in the lungs. So we have this alveoli right here, and these are the blood vessels. And usually oxygen is going to be absorbed into the blood vessels, and carbon dioxide is going to be transported into the alveoli so that it could be eliminated from the body. But now, because this capillary network or these blood vessels are now so dilated, what happens is fluid is now going to go here. So when fluid goes into the alveoli, notice that in order for oxygen and carbon dioxide to penetrate, they're going to have to go through this fluid. So it's almost like if this is the fluid, and this is the oxygen, and this is the carbon dioxide, the oxygen needs to go over here, but it couldn't because of all this fluid. And the carbon dioxide cannot go in as well in order for it to be exhaled. That's what's going to happen. You're going now to have poor gas exchange. All right, so in our alveoli, there are two types of epithelial linings or pneumocytes. Type 1 pneumocytes are the ones that allows the oxygen and carbon dioxide to pass. But there's also another type of epithelial lining, and these are the type 2 cells, and this type 2 produces surfactant. Okay, so we had already talked about what happens to the type 1 cells. They're now going to be overcome, and therefore oxygen and carbon dioxide can no longer pass or exchange. So difficulty in exchanging O2 and carbon dioxide. Right? And over here, oh geez, sorry about that. And over here, when the surfactant is going to be diminished, what's going to happen? What is the purpose of a surfactant? All right. So I always have a balloon here because when I teach these classes, I always need a balloon. But let's say that you have a balloon over here, like the alveoli. But now when you collapse and there is no longer going to be a lubricant inside, what's going to happen to this balloon? They're going to stick together. You understand that? The walls of the balloon are going to stick together. If they stick together, would it be easier to blow it up or would it be more difficult to blow it up again? It would be harder, exactly. So what happens with the surfactant production is it's going to be diminished. Therefore, it sticks together. The alveoli sticks together. And this leads to collapse. So there are two things that happens. You're drowning the alveoli and you're also collapsing the alveoli. And therefore, gas exchange is going to be compromised. And that's exactly what happens with ARDS. So in this particular slide that's coming up, we're going to see the pathophysiology of ARDS. So we have bacterial antigens that attract white blood cells, and then they release toxins called endotoxins, and the release of them causes your vasodilation. And of course, what's going to happen is that you're going to have vessel leak. It leads to pulmonary edema. It leads to hypoxia. So all these are going to happen whenever you have ARDS. So it begins with your alveolar capillary injury, and now you're thinning out the walls of the blood vessels, and there's going to be an influx of fluid into the alveolar space. So that's exactly what happens in ARDS. All right, so what are the causes of ARDS? Well, we divide the causes of ARDS into two broad categories. One, those that have direct lung injury, and the other one is going to be indirect lung injury. So examples of direct lung injury would be pneumonia, or maybe aspiration, for example, bruising of the lungs as a result of chest trauma, or maybe the patient is near drowning. Those are examples of direct lung injuries. But there's also conditions that cause indirect lung injury, meaning to say that the pathology is not in the lungs, it's outside of the lungs, but it eventually causes lung damage or lung involvement. And this would include your sepsis, your trauma, severe trauma to the head, to burns, for example. It could also be as a result of pancreatitis, and the other ones are non-cardiogenic shock. So all these conditions are going to be non-pulmonary in origin. Okay, so those are the causes of ARDS. They could either be pulmonary, intrapulmonary, or non-pulmonary or indirect lung injuries. Okay, let's take a look at this poll. All right, so the correct answer is letter B. As we all know, the surfactant decreases the tension in the lungs, and therefore, when the alveoli sacs will be out of surfactant, there's going to be a sac that easily collapses. This is the condition known as atelectasis. All right. So let's go to the signs and symptoms of ARDS. So the early symptoms of ARDS usually occurs within a few hours to a week after a lung injury. But in the early phases, the signs and symptoms are hard to detect. At first, the fluid is leaking into the interstitial spaces, so the lung sounds may not be abnormal. In fact, they may be normal, or sometimes there might be a random crackle here or there. But as the patient's condition progresses, the patient will now have difficulty in breathing, and so air hunger is going to be experienced by the patient. Then, as time goes on, it moves now to a full respiratory failure. So what are the signs of respiratory failure? Tachypnea, for example, difficulty in breathing, hypoxemia, even though the patient is receiving a high amount of oxygen. This is what is known as refractory hypoxemia. So if I give you 100% oxygen, your oxygen level should go up. But in these patients, they do not go up. So this is what's known as refractory hypoxemia. It could also be reflected by a decrease in O2 saturation, as well as mental changes. Now, remember that whenever you're taking care of patients, a decrease in mentation is usually as a result of poor oxygenation. Restlessness is a symptom that is going to be associated with hypoxemia, whereas sedation, or meaning to say the patient is going to be very sleepy or very unresponsive, that usually is going to be CO2 retention. So when there is a decrease in oxygen, the patient will have restlessness. When there is an increase in carbon dioxide, there is going to be, the patient will look like they're sedated. And that is known as CO2 narcosis. All right, so carbon dioxide is a depressant, and therefore, for the mental state, and therefore the patient is going to be obtunded or unresponsive. Patients with hypoxemia are going to be restless. So whenever you're taking care of a patient with respiratory distress or respiratory problems, if they become restless, that means to say they lack oxygen. If they're very sleepy, you cannot wake them up. That means to say that they're trapping carbon dioxide. That is what is known as CO2 narcosis. All right? Oh, I am sure that this one again is going to be only single choice, but there's more. So could you just go ahead and type your responses onto the chat box? So I'm just going to close this poll. So as a nurse, you know acute respiratory distress can be caused by direct or indirect lung injury. What are the indirect causes of ARDS? Okay, very good. So sepsis is one, blood transfusion is one, and pancreatitis is going to be the other one. So it's C, D, and E. Okay. So indirect causes are processes that cause inflammation outside of the lungs. So the issue arises somewhere else. Therefore, sepsis, the infection, is going to be, what do you call that? Either in the lungs directly or indirectly. Okay. All right. So what are the physical findings of patients who are diagnosed with ARDS? Well, physical findings, unfortunately, are often non-specific, but they may include tachypnea or rapid respirations, and they might have tachycardia or fast heart rate, and the need for higher amounts of oxygen. Okay, so when you are, that's correct, Lindsay. Anything that is direct is lung related. Great. I wanted to define for you FiO2. FiO2 is fraction of inspired oxygen. Right now, what is our FiO2? What is it that you and I are breathing? How many percent of oxygen? Hello? What is your FiO2 right now? No, we are breathing 21% of oxygen. That is our FiO2. Okay. Now, if you give 1 liter of oxygen, for example, you're going to increase that to 24%. If you're giving 2 liters of oxygen, it becomes 28%, and 3 liters would be 32%, and so on. Okay. It increases by 4%. Actually, we breathe 20.88% of oxygen. So just add 4 for each liter of oxygen. Okay, so if I am giving you 5 liters of oxygen, what is your FiO2? If I give you 5 liters of oxygen, what's your FiO2? Yes, 40%. Okay, so do you understand now what FiO2? It's the fraction of oxygen that you are breathing. All right, so why did I say that? The reason I said that is the respiratory distress of the patient requires more and more FiO2. So the patient might be put on 1 liter of nasal cannula. That's only going to be 24%. It probably will not be enough. So it keeps building up to the point that the patient will have to require 100% FiO2. All right, so that's the progression of this particular condition. And ARDS is not a disease, but rather a condition that is resulting from another disease process. All right, so you would have respiratory distress. The patient may be febrile or hypothermic. They are going to have hypotension. And because they are going to have hypotension, when you have massive vasodilation, your skin is going to compensate. And it's going to be, what do you call that? Constricted. The skin is going to be constricted, but the blood vessels are going to be dilated. And of course, during auscultation of the chest, there are diffuse crackles. which is going to be the sound of collapsed alveoli popping open with inspiration. So those are the findings that you're going to see in these patients. All right, your answers, please. I didn't activate the poll. Okay, very good. All right, I see your responses. Can you go ahead and do the poll so that I could see better?
The poll didn't come up for this
It
one.
didn't. Okay. Huh. This slide. It's refusing to launch for me, so that's okay. So the correct answer here is letter C. This is exactly my point earlier. A hallmark sign and symptom of ARDS is found with refractory hypoxemia. What is refractory hypoxemia? This is where that although the patient is receiving a high amount of oxygen, in here in this particular instance, 100%, the patient is still hypoxic. So option C is the answer because it states that the patient arterial oxygen level is remaining at 45. Usually our normal is supposed to be 80 or above, okay? So when we're breathing okay, our oxygen level, our PaO2, the pressure of arterial oxygen, is going to be around 80 and higher. Now, in patients with ARDS, they're going to be very low. We want to increase that to at least 60 because otherwise they're not going to be oxygenated. All right? All right. Is the poll showing now? Okay, thank you very much. Okay, so let's go ahead and discuss this, all right? Now, letter A, it says it develops because the exocrine glands start to work incorrectly. Well, there are no exocrine glands, but you remember those two types of cells that are going to be present in your alveoli, type 1 and type 2, right? The type 1 allows oxygen and carbon dioxide to exchange. The type 2 are the ones that secretes surfactant. Now, ARDS causes chronic obstruction of airflow. It's not COPD. chronic obstruction, it refers to a condition such as what happens with emphysema, as well as in chronic bronchitis and chronic asthma. So that is not it. And what is the pathology actually? Letter D. You remember that there is going to be a permeability, an increased permeability in the capillary membrane of the alveoli. And when you increase the capillary permeability, you remember that rubber band that I told you? Well, this leads to fluid collecting in the alveolar sacs. Okay? All right. So how do we, what other diagnostic workups are we going to do in patients suspected of ARDS? Well, the diagnosis of ARDS is actually going to depend on several criteria. But one of those criteria is going to be lung infiltrates on the chest radiography. You will see the lungs very white, similar to this one. Now, remember, when the lung is not going to be air-filled, what's going to happen is it's going to be very translucent. It becomes white out. And this becomes the hallmark for the diagnosis of ARDS, bilateral lung infiltrates. And there's also going to be a PaO2 over FiO2 ratio of less than 300. So that's a little bit advanced. It's never going to be a, what do you call that? As in Nclex. But just remember that this is a measurement of when you increase oxygen on the patient, the PaO2 should rise. But in patients with ARDS, even if you give them 100% of oxygen, the PaO2 or the arterial oxygen blood still does not go up. Okay? And the other ways in which we could actually diagnose it is through bronchoscopy to see if there are any visual changes that could be seen. And of course, to see the precipitating event of infection, CBC with differential, CMP or complete metabolic profile, magnesium, calcium, phosphorus, lactate. All those are going to be very, very important, including your coagulation panel, troponin, and your ABG. So all these are going to be relevant so that we can manage the patient during the acute phase of the disease. All right, so exactly how do we measure, or how do we manage, I should say, patients with ARDS? Well, there are 5 P's that we always have to remember when we are taking care of patients with ARDS. All right, so what are these 5 P's? Well, these are perfusion, positioning, protective lung ventilation, protocol weaning, and preventing complications. So I'm just showing you the first P. And the first P is going to be perfusion. All right. So the goal of care for patients with ARDS is to maximize the perfusion in the capillary system by increasing the oxygen transport between the alveoli and the capillaries. So to achieve the goal, how could we do that? Well, we need to increase the fluid volume. So this has got to be done without overloading the patient. So we give crystalloids to replace the fluids that have leaked from the capillary into the alveolar spaces. So that is one. But we are going to be very careful in giving fluids for the patient, because if you give too much fluid, what's going to happen? You're going to have pulmonary edema or heart failure, right? And so an overload, yes. And therefore, you don't want that to happen. So we need to evaluate how much fluid we're giving by monitoring their CVP, as well as their urine output. And because they are usually in intensive care, we also could insert a pulmonary artery catheter so that we will know if we're drowning them or not. Now, other measures are going to be to increase perfusion, you can increase the way in which the heart pumps. And therefore, to increase this efficiency, we give them drugs that are inotropics. Inotropy refers to force of cardiac contraction. Okay, so what are some of those drugs that are inotropic? Well, there are two inotropic agents that we use in the ICU, and they include your dobutamine or Wtrex, and the other one is milrinone, which is also known as Primacor. And then, of course, we could also use those pressure medications that causes vasoconstriction. So what are those medications that would cause vasoconstriction that could be given IV? So again, norepinephrine and dopamine. Okay, so those two drugs are the ones that we usually give for these patients. So that's the first P, is perfusion. All right, the next thing that we're going to do is, of course, ventilation in order to maintain their pulmonary function. So usually patients who have ARDS would have to be ventilated, and therefore we need to insert an endotracheal tube. And we could also, before doing that, give non-invasive ventilation like high-flow nasal cannula. So remember that high-flow nasal cannula is going to have the ability to give oxygen at higher concentrations, but it's moisturized. And that's the reason why it's favored rather than a typical way of giving oxygen. Because when you give oxygen, it is going to be drying. It dries the mucous membranes. By giving high-flow nasal cannula, if you have experienced that, it goes to a moisturizer, and therefore that oxygen that's given to the patient is not going to dry up the mucous membranes. And then, of course, non-invasive positive pressure ventilation. I don't know if you've heard about CPAP and BiPAP. Well, CPAP is a way of forcing air into the lungs. And so let me just explain that a little bit, if I can get this. There you go. All right, what is CPAP? CPAP is continuous positive air pressure. Continuous positive air pressure. So a best way to explain this is, supposing you're riding in a car and you're feeling nauseated. So you usually open the window and put your face outside the window. And what happens to the air going towards you? The air is being pushed towards you, isn't it? It's going to make you breathing in much better because there's a force that is pushing the air towards you. That is what is known as CPAP. Now, BiPAP, on the other hand, is the word bi, meaning to say that it is two ways, meaning that the pressure on inspiration might be different from the pressure that we will exert on your expiration. So we usually will have the inhalation phase much stronger than the expiratory phase. So that is what is known as BiPAP. Did I explain that okay? Are there any questions about CPAP or BiPAP? All right. So that is exactly what we do before we even intubate the patients. Okay. So we give high flow oxygen, and then we try non-invasive positive pressure ventilation, which would include your CPAP or your BiPAP. All right. So those are the efforts that we're going to do in order to maintain oxygenation for the patient. All right. How about the others? Only two voted. Okay, so a patient with near drowning event has a respiratory function deteriorating. What finding on the chest x-ray is indicative of ARDS? So remember, the infiltrates, whiteout infiltrates bilaterally is going to be the correct response. This is a pronounced whiteout that is present in patients with ARDS. All right, the other thing that we do is protective lung ventilation. That's the other P. So what does this include? Well, we're going to make interventions related to the ventilator that is going to increase or protect their lungs, I should say. What is the danger of putting a lot of air into the lungs? Well, the danger is that you could cause rupture of the alveoli, and that is what's called barotrauma. So we want to protect the patient from barotrauma. That's the rupture of alveoli as a result of putting too much air on the patient. And so what we want to do is to give air that is less than 30 centimeters of water. The pressure is not going to be very great because otherwise there's going to be a danger of rupturing the alveoli. We also want to make sure that we only give oxygen at around 50 to 60%. So what is the problem? Why don't we want to give the patient oxygen that's higher than 60%? Okay, so let me explain. Anytime a patient is receiving oxygen that's greater than 60%, that means to say they're very, very serious and we are at the end of the line. Now, when we breathe, the alveoli expands, and when we exhale, the alveoli deflates partially. It does not totally deflate like this. Understand that? So inhalation and exhalation, the alveoli will remain open. Why is that? The longer the alveoli is open, the more chance of exchange of oxygen and carbon dioxide it's going to be. All right. So over here, if this is the capillary, oxygen is going to be absorbed into the capillary, carbon dioxide is going to go out. So if you have it open like this, you are still going to maintain the exchange of gases despite the fact that you had exhaled. So, but Dr. Tom, I thought that when you exhale, your balloon is going to be totally deflated. Well, it is not. And the reason is God created an atmosphere that has 78% nitrogen. So you remember 21% or 20.88% is oxygen and 1% is other gases. This is what we are breathing right now. Why did God give us 78% of nitrogen? What's the purpose of that nitrogen? Well, the purpose of that nitrogen is to keep this alveoli open. Okay? So you want to maintain this thing, and this is what is known as physiologic PEEP. And PEEP stands for positive and expiratory pressure. All right, so that's natural. God gave us this positive and expiratory pressure. So do you understand what the function of physiologic PEEP is? So in patients now that are ARDS, what we could do to increase and prolong the exchange of gases, therefore, is to do artificial PEEP. Okay, so when we do artificial PEEP, what are we actually doing? We are actually prolonging the expansion of this alveoli. And the reason is we want to maintain the exchange of carbon dioxide and oxygen even with expiration. Is that clear so far? So instead of us giving a lot of oxygen, we would rather do PEEP. So why again is that? Okay, let me just digress a little bit. And I want to change colors. So what did I say was 78% was the pressure of nitrogen that is keeping this open, correct? 78%. Right. If I give you oxygen at 100%, which one is going to be stronger, nitrogen or oxygen? Which one will be stronger, the oxygen or the nitrogen? Yes, the nitrogen will be stronger because it's 78%. I mean the oxygen at 100%, I'm sorry, the oxygen will be stronger. And so what it does is it blows off or washes out the nitrogen away. So when you wash the nitrogen away, what's going to happen to your lungs? It's going to collapse. That's the reason why we do not want to give oxygen that's greater than 60% as much as possible to around 100%, because you are now going to compete with the strength of the nitrogen and you're going to wash it off. So when you give patients oxygen that's greater than 60 to 100%, you are going to have nitrogen wash off. And the consequence of nitrogen wash off is atelectasis. Is that clear? Great. Okay. I'm losing track of time. I know we have passed 1 hour, so let's go ahead and take a 5-minute break, and then we'll come back and finish with this discussion. Okay? Take a 5-minute break. Okay, so 5 minutes is up. We're going to go ahead and get started again. All right, so other things that are relative to the ventilator is what is known as the tidal volume. See over here, TV. TV is tidal volume. So what is tidal volume? Okay, so it's the amount of volume of air actually that is going to be breathed in and out of a patient. So for example, if I blow this balloon and I measure the amount of air that is in the balloon, that is what's called tidal volume. So we want to give the patient enough volume of air, but not too much, because too much might cause barotrauma. So our objective is to keep it as less as possible without compromising the patient. We also want to maintain the O2 saturation of the patient at around 88 to 95%, and the pH at around 7.30 to 7.45. All right. So you now understand what PEEP is. And so those are the interventions that would allow us to increase the oxygenation of the patient. Another thing that we do to patients who are going to be with ARDS is prone positioning. And the reason why prone positioning is very important is because it actually improves ventilation perfusion ratio. In other words, it improves the circulation to the lungs, it improves the aeration of the lungs, and therefore the patient will be improving as far as oxygenation is concerned. And it also increases the effects of PEEP, or positive and expiratory pressure. So prone positioning is a very, very good thing. And I'm sure that you have done that in patients who had COVID during the COVID pandemic. All right. So let's take a look at this question. All right, let's answer this question. Now, in the beginning, you remember that patients who are having ARDS will have tachypnea, right? So they will have an increase in respiratory rate. When you increase your respiratory rate, what happens to your CO2? So if you just watch me, what happens to your CO2? Anyone? Okay, so you become alkalotic, you decrease, oh my goodness. You decrease your PCO2, okay? So if you decrease your PCO2, this is going to be the result, alkalosis. All right, so if we take a look at the pH of 7.9, this is alkalosis. This is normal because you remember pH is 7.35 to 7.45. And then Of course, over here, this is acidosis. And over here, this is also acidosis. So as you could see, the early part of ARDS is going to be characterized by a respiratory alkalosis. Okay, so as you could see, the CO2 over here is 30 and normal CO2 is 35 to 45. All right, so the correct answer is letter A. Another way that we manage patients with ARDS is ECMO. And I don't know if any of you have had the experience of having ECMO during the COVID pandemic, but ECMO, short for extracorporeal membrane oxygenation, is going to be removing the blood and putting it into a machine that oxygenates the blood itself. So that's the simple explanation of ECMO. And usually this is going to be a last-ditch effort in order to oxygenate the patient properly.
It's only one choice, but it's a stata.
Did the poll launch?
I got it, but it was only one choice, even though it's for stata.
Oh, okay. Yeah, again, I'm sorry. Yeah. All right, I got it. So which findings indicate that a patient is, I don't know what happened here. The prone positioning was beneficial for your patient with ARDS. All right. So if there is going to be improvement, should the lung sounds improve? And the answer to that is yes, right? Development of a VQ mismatch, meaning to say ventilation perfusion is going to be mismatched, that's going to be bad. That means to say it's worsening. So that would not be correct. So A is correct, B is incorrect, and letter C is going to be a positive finding. The PaO2 increasing from 59 to 82 is good. This means to say that the prone positioning did what it was supposed to do. And PEEP needs to be titrated to 15 millimeters of water. That means to say that it's getting worse, okay? So the correct responses are letter A and letter C. Okay, so let's go to other treatments for ARDS. And obviously, it's going to include the administration of antibiotics as well as the administration of steroids. Clients are given steroids to decrease inflammation in the respiratory tract. And usually, these patients will also get low molecular weight heparin, like enoxaparin. And this is to prevent thromboembolism, unless, of course, it's contraindicated. And then enteral nutrition, the earlier we give the patient food, the much better the result is going to be. And then, of course, whenever you are in a severe physiologic state, when you're sick, there is a chance for you to develop peptic ulcers. And these ulcers are what's called stress ulcers. And so anytime a patient is critical, we always provide them with proton pump inhibitors in order to prevent stress ulcer formation. And then, of course, sometimes we might have to give them nitric oxide, which is the same way as nitrogen in the environment. And sometimes patients fight the ventilators, and therefore oxygenation is not going to be achieved. So we might have to paralyze them as well. Usually we do this during the first 48 hours. And it has been found out that if we paralyze them and totally control them with a ventilator, that the 90-day survival of these individuals is going to be increased. Now, whenever the patient is critically ill, obviously there's going to be potentials for different complications, DVT among them, pressure ulcers, poor nutrition, and ventilator-associated pneumonia. So all these things have to be undertaken in order to prevent these complications. Okay, so let's look at this poll. Okay. I think you missed that part, that why we do PEEP. You remember we said that PEEP was given, I mean, it's important. Do you remember physiologic PEEP? All right. So PEEP is when you inhale and then you exhale like this, and applying PEEP is keeping this alveoli open. So the correct response is letter D, all right? So by keeping it open, you're prolonging the time of exchange of oxygen and carbon dioxide, all right? Okay. Yeah, so it's letter D. Letter A, this assists with breathing in and out and helps improve air. That would be CPAP and BiPAP, not PEEP. All right, understand that? The pressure of breathing the air, the positive pressure, is going to be CPAP or BiPAP. Okay? All right. So in as much as the patient is going to be on a ventilator, we have to make sure that we decrease the possibility of ventilator-associated pneumonia. And so anytime a patient is on a ventilator, we always have to have several strategies in order to prevent them. So, for example, is going to be mouth care. And so what do we do as far as mouth care is concerned? We need to brush their teeth every 12 hours and oral care every 2 to 4 hours with an antiseptic and applying moisturizer to the mucosa and the lips. And then, of course, the earlier we are going to institute these precautions, the better it's going to be. And so it includes elevation of the head of the bed and also daily sedation vacations. And over here is going to be the fact that we have to make sure that we perform mouth care with chlorhexidine after brushing the patient's teeth. Okay, so those are the important things that are going to be included in the VAP bundle. And in this separate slide, it's going to tell you about the head of bed recommendation. The recommendation is that they must be at around 30 to 45-degree angle. And then, of course, the earlier we extubate the patient by weaning them, the better it's going to be. And the other thing that is going to be part of the bundle is frequent changes of the ventilator circuit. So this usually is going to be 7 days. In some institutions, it's going to be more than that, because the less you break the system, the better it's going to be. And then, of course, the oral chlorhexidine that I told you. And this is going to be very, very important in order to prevent ventilator-associated pneumonia. And then, of course, prevention of stress ulcer. So we use proton pump inhibitors. So what are these medications? Examples of proton pump inhibitors would be your pantoprazole, omeprazole, so things that end with azole. All right, PPI are going to be the things that end with azole. So omeprazole is an example of that. All right, H2 blockers are going to be the ones with end with tidine, like cimetidine. And antacids are not recommended by the CDC. Okay, so I think that ends the presentation except for this one. So let's now go to the case study. For those of you who would like to go back to it, I sent you in the chat box the link to the case study. Do that after the class or anytime. And I also would like for you to do the evaluation, okay? So we have a 78-year-old female admitted to the medical intensive care unit, and the client was admitted to the ICU in respiratory distress after minimal response to high flow oxygen for a pulse oximeter reading of 83% on room air. Crackles were heard bilaterally in the lower lobes with diminished breath sounds in the right middle lobe. S1, S2 auscultated, bowel sounds times 4 quadrants, skin warm and dry, intact, vital signs 99.8, 37 heart rate 110, and respirations of 30, with a blood pressure of 168/90 and a pulse ox of 87% on 100% non-rebreather. Is that good? Is 87% good on
No,
100%?
no.
No, it's not good. So don't be fooled by the fact that even if it's 90, it will not be good because the patient is on 100% oxygen. All right. So these are the lab values. We see that the pH is 7.2 and the O2 is 75 and the CO2 is 51 and a bicarb of 28. So if we are trying to interpret this, okay, 7.2 is acid. Where are you, Ben? All right, and 51 is acidosis, and 28 is alkalosis. So we have a respiratory acidosis with partial compensation. All right, for those of you who are not sure about arterial blood gas, I have a very, very good tape, very, very brief lesson on ABG interpretation on YouTube. So I encourage you to do that because we will not have time to do that over here, okay? So we also see that the patient has a high WBC, obviously, and the other things that are going to be abnormal over here are your lactate. Oh my God, 4.5. Okay, and gram-negative cocci. Okay, so remember those findings. And now the question is, which four findings are the most urgent? Which four findings are the most urgent? May I see your selections? Okay, definitely that lactate. Correct. I agree with you. This would be the number one thing that I would do. All right. And what else? Do you like the pH? 7.2. This is severe acidosis. So this would be another one. Okay. And the respiratory rate of 30 beats per minute, that is so high. So this indicates that the patient is in respiratory distress. And your pulse oximeter of 87%, despite the fact that he or she is on 100%, that is going to be significant. All right. So if I were doing this C, D, G, and I, so think of it in the context that you already have ARDS. So you are already told that the patient has ARDS. I mean, you're already suspecting that the patient has ARDS. So think about the bad things that need to be addressed. And they would include your, obviously, lactate level, the pH, which is severe acidosis, and then, of course, your respiratory rate and your pulse oximeter. So they're all related to respirations. So if you think about this, if you think about this, they're all related to respirations except for the serum lactate level. Okay, so let's go to the next question. For each finding, choose to indicate if it is consistent with acute respiratory failure or pneumonia. Each finding may support more than one condition. Each column must have at least one option selected. Okay. So for the crackles, would you have crackles in ARDS? Yes or no? Would you have crackles in ARDS? Yes. Okay, very good. Do you also have crackles in pneumonia? Do we develop crackles also in pneumonia? Yes, very good. Okay. How about a pulse oximetry of 87% despite the 100%? This certainly is going to be in there, but it could also be happening in pneumonia as well. And that's why we intubate patients who have severe pneumonia. And so that's a possibility. The PCO2 of 51, however, this is going to be high, right? It probably is going to be associated more with acute respiratory failure, and the pH of 7.2 is going to be one that we would be associating with in patients with acute respiratory failure. All right. So in these situations, how does Nclex score you? Okay. So you would score a 1 for answering this, 2. Okay. If you answered both of them, you would also have 1, and then 1 over here and 1 over here. But let's say that you put this thing and in here, then you're going to be incorrect. All right. Or in the case of letter A, you only check acute respiratory failure, but not in pneumonia, you only get 1 point. I mean, you will not get a point, I should say. Sorry. Okay. All right, so let's take a look at the next question. What does the nurse determine is the priority for this client's care? Can I see what your answers are? Okay, only one answered. Anybody else? Okay, so you remember what the problem was. It was severe respiratory distress. So therefore, we have to intubate the patient. Now, always remember this as a clue. Whenever a patient's PO2 is less than 50, or the PCO2 is greater than 50, always think about that this is the indication for buying a ventilator. So this is the marker that we say buys the ventilator. Whenever a patient has a PO2 of less than 50 and a PCO2 that's greater than 50, we automatically ventilate those patients because they're not stable as far as respiratory status is concerned. Okay? All right. So let's go to the next question. So the nurse plans care for the client after beginning mechanical ventilation. For each potential intervention, click to specify whether the intervention is indicated or not indicated to include in the plan of care. All right. Should we administer sedatives? Think about when you were taking care of patients and you saw patients in the ICU. Were they awake when they were intubated? You would need this in order. You remember I said they even paralyze the patient in order to have total control of their ventilation. All right, so this would be indicated. How about suctioning every 2 hours? Is that good or bad? Indicated or not indicated?
Indicated.
All right. We never suction routinely. The reason is when you suction, you are suctioning secretions, but you're also suctioning oxygen out. All right. So we never schedule suctioning every 2 hours. It has to be PRN only. Okay, remember that. We never, ever schedule suctioning on patients. It always has to be PRN. Okay. How about amiodarone? Do you know what amiodarone is? Arone means to say that this is an anti-arrhythmic agent. So this would not be indicated because there's no situation mentioned that the patient is having any arrhythmia. All right, would you give antibiotics?
Indicated.
Yes, because the patient has sepsis, correct? Position supine. Is this
Not
a good?
indicated.
Not indicated. What kind of position should be? It should
Prone.
be Yes, prone positioning or 30 to 45 degrees. All right. And obtain an electrocardiogram. This would be indicated because the patient is critical, and therefore we always need to monitor them. Okay. So the nurse receives orders. Choose the 3 orders that the nurse should implement first. Okay. Is inserting a urinary catheter a priority?
No.
No. Okay, so we could eliminate this, right? All right. But we just had the patient intubated, by the way. What do we need after intubation? What is one procedure that we need after intubation? Anytime you intubate a patient, there has got to be a chest x-ray right away to check for placement. So chest x-ray is going to be indicated. And then, of course, giving over here, the patient is very serious but doesn't have any IV. So we need to start an IV, right? We cannot give this amoxicillin IV and this midazolam IV if we don't have an IV. So we need to start this IV. And of course, the patient is going to be intubated, so we also need to give the midazolam. All right, so do you remember that sedation should be given to decrease agitation and also to decrease the risk of the patient pulling out the tube? So all these we do right away after intubation. Chest x-ray, we need to sedate the patient, and then of course we're going to make sure that we have an IV first of all in order that we can give those sedation. So these are the correct answers for that one. All right, and now we're going to what happened over here? The nurse reassesses the client at 10 o'clock and compares the findings at 9:30. For each finding, click to specify if the finding indicates that the client's status is improved, declined, or is unchanged. Okay, so let's take a look at the heart rate. The heart rate over here was 110, and the heart rate is now 100. Is this improved, decline, or unchanged?
Improved.
Yes, this is improved. Obviously, he's not as stressed, physiologically stressed as he was. How about the temperature? The temperature was 99.8, and now the temperature is 99.8. So what should we put? Unchanged. Very good. The respiratory rate was 14 over here, and the respiratory rate is 14. This is also unchanged. And the blood pressure, what was the blood pressure? 180 over 90. And the blood pressure is 150 over 70.
So improved.
Improved, very good. And the pulse oximetry is 96 and then 96 over here and 93 over here.
So declined.
Declined, very good. And how about the agitation? Client is restless over here, and the drowsy -1 sedation scale. So this means to say improve. The agitation has improved. Very good. So I encourage you to please go to the website, to the exercise later on after you have forgotten everything I have said to see if you can recall it. So the link I sent you, and I would appreciate it if you also do the evaluation. Somebody did do one just to make suggestions or general impressions of the course. You know that I am a continuing contract with Broward College, which means to say I'm not a permanent employee, so they could fire me at any time. So I have to make sure that I show evidence that I'm doing good. And so your evaluations are going to be very useful. Okay. So once again, I do thank you very much for spending the evening with me. I must tell you that I did go to get my global entry interview, and that was so quick, and so that was okay. So thank you very much for understanding. I'll see you tomorrow, okay?
Thank
So,
you.
yeah, tomorrow will be the same time at 4 o'clock. We'll go back to the usual time. All right?
Okay. Yeah.
Thanks
Thank
a
you.
lot. Thanks a
Thank
lot,
you.
everyone. Okay,
I'm so sorry,
bye-bye.
Professor. I've been in and out, so
That's okay, Chantel.
yeah.
Just as long as you got something from it, that would be okay.
I'm driving. I'm trying to.
You're okay.
All
That's
right.
okay. All right.
All right.
Good night.
Good night.